Hi everyone, welcome to the webinar today. My name is Carrie Lynn. I'm a knowledge translator with CIPSRT. And if this is your first rodeo, we want to make sure you're in the right spot. So this is an overview of a research study on a peer-led caring contact intervention following calls to a crisis line by public safety personnel. So CIPSRT is housed at the University of Regina, located on Treaty 4 and Treaty 6 territories, the ancestral lands of the Cree, Saulteaux, Dakota, Lakota, and Nakota nations, and the homeland of the Métis. And just a quick plug for next week, we actually have another webinar going on if you'd like to be a part of it. It's from the Family Matters Research Group interactive series, Introducing Garnet Families. So if you'd like to attend that, you're more than welcome to register. And everyone here is in listen only mode. This is just to limit ambient noise, any feedback during the presentation. Today's session is being recorded and you will receive a copy about 48 hours after if you've registered. So please also use the question box to ask questions throughout the presentation. And if you'd like to access captioning, you can use the following links. These are here for you. They will also be posted in the chat. And this is just a disclaimer slide before we get started here. You can have a quick read through that if you haven't seen it before. And I'm very happy to have the panel here, so thank you very much. And we will begin the presentation with Dr. Janet Ellis.
Thank you so much, Carolyn. I will be providing a brief overview of this study, which is CIHR funded. And as Carolyn said, it's on a peer-led caring contact intervention following calls to a crisis line by public safety personnel, which of course I'm going to explain a bit. Next slide. And I'm so grateful to Nick, Alison, and Dave for being here, experts in the areas that this study touches upon. Nick Carlton will be talking about mental health issues among public safety personnel. Alison Crawford will be speaking to 988, Canada's national suicide crisis helpline. Dave McLennan will be speaking to Boots on the Ground. And I'd like to again say thank you very much to Erin Palachi, who's my research coordinator, for putting these slides together, and to very much acknowledge Mahia Habib, who is our project coordinator. Next slide. So what is the CCPI for short? Well, it is a novel intervention which combines two evidence-based ideas. So caring contacts is an early follow-up contact for high-risk individuals at high-risk times. And in general, we know that public safety personnel are a high-risk group of individuals, and that those who call a crisis line are at higher risk. We also know that peer support has evidence for reducing suicide and post-traumatic stress injury, and we know that it's appreciated and acceptable to PSP. We've chosen the timeline of these two telephone calls of within 48 hours and within a week of the initial crisis call, following a national suicide guideline for prevention of suicide after crisis. Next slide. So Caring Contacts was developed by Jerome Motto, who was a psychiatrist in the 1970s. He did military service, and in his military service in the Second World War, apparently he found letters from home very comforting. It made him feel less alone. And then he came back and he thought about high-risk people being discharged from psychiatric wards, and especially those who seemed to be lost to follow-up, and decided to send letters to these people and found that if they were non-demanding, caring letters, they did reduce suicide in high-risk individuals. And many studies in various populations have found similarly, so far we haven't yet had a study published in specifically for PSP, although there are studies, for example, amongst veterans. Next slide. So how exactly do these caring contact letters help? Well, they've been found to increase a sense of security and being cared for by the system, being cared for by the crisis line, for example, that there's follow-up. They promote a sense of belonging and not being so isolated, and offer validation that this is a high stress time and perhaps more resources would be needed. Next slide. So again, the rationale was simple. We combined these two ideas into this intervention, and we wanted to know, is it feasible to implement, and is it going to be feasible and acceptable to PSP in terms of uptake, especially PSP who have accessed a crisis line. Next slide. And apart from looking at feasibility and acceptability of this intervention, we wanted to understand the experience of PSP in crisis, as well as understand more about what works and what doesn't work, what was the feedback about the experience of receiving it, what was the experience of the peer facilitators, and to inform future interventions for PSP in crisis. Of course, it also helps to make a crisis line more meaningful and relevant for PSP, and enhances evidence-based provision of support. Next slide. Over to Nick.
Thank you very much, Dr. Ellis. I'm Nick Carlton. I'm a professor of clinical psychology here at the University of Regina, and I'm currently serving as the scientific director for CIPSRT. And it's my pleasure and privilege to be here today with all of these experts. So I'm going to provide some of the background, and I'll do this relatively rapidly because I expect many of you have heard this background before, and I think we're all eager to make sure that we're continuing to hear from everybody else here. So let's start with some background on public safety personnel. This was a phrase that was created to be more inclusive than focusing specifically on first responders. First responders, of course, include our paramedics, our firefighters, and our police. That said, that term sometimes can get conflated, and there's some legislative reasons why that term might refer to different professionals. So several years ago, a community came together and said, we need a broader phrase, something that will allow us to talk about people who are potentially providing first response services but aren't normally thought of as first responders. So that includes our border services, that includes some of our CAF members and veterans, our correctional service and parole officers, certainly our career and volunteer firefighters. A quick note, there's more volunteer firefighters than there are career firefighters. Most of Canadian firefighting is done by volunteers. Our Indigenous emergency managers, our operational intelligence personnel, our paramedics, police officers, our public safety communicators, and our search and rescue personnel, all of whom get exposed to orders of magnitude more potentially psychologically traumatic events than the general population. So someone like myself will be exposed to 5 or fewer such events in my entire lifetime, possibly never if I'm lucky. Whereas every time one of those experiences happens to any one of us, our public safety personnel are engaged, which means that they're exposed to hundreds, thousands, maybe tens of thousands of those events during the course of their career. And we believe that those can and do negatively impact their mental health over time. Let's, oh, sorry, I think we should be on the next slide. That's my bad. So some of these potentially psychologically traumatic events include things like crime, violence, accidents like car accidents, natural disasters, a variety of disturbing materials, and other emergency situations. Those elevated exposures are a significant component of the elevations then that we see in the prevalence by which they might screen positive for a variety of mental health disorders like major depressive disorder, panic disorder, post-traumatic stress disorder, as well as other symptoms and other challenges like substance use issues or difficulties with anger or difficulties with suicidal ideation, planning, and attempts. So let's click to the next slide. In addition, we also know that they're exposed to a variety of different elements of these events that can be problematic. So we've reframed a lot of the conversation around post-traumatic stress so that we recognize it first as an injury. And post-traumatic stress injuries themselves may result in a variety of different kinds of diagnoses or no diagnoses at all. Post-traumatic stress injuries subsume a large category series of occupational injuries, operational injuries, and organizational injuries, broadly speaking. When we talk about post-traumatic stress injuries, they're also associated, unfortunately, quite often with moral injuries. So neither PTSI nor moral injury are diagnoses, but they're both concepts that relate to the experiences of all of our public safety personnel while they're on duty. A post-traumatic stress injury, this is more often something you hear used with military or PSP communities, and it could be any number of mental health conditions. So I could be exposed to a potentially psychologically traumatic event, like a car accident, and it might result in me being diagnosed with PTSD based on my symptom profile. But I might also meet criteria for another disorder instead, like major depressive disorder or a panic disorder. Or I might not necessarily fit in any category super well, in which case I might still have an injury that requires assistance, but it might be a more difficult diagnosis, or it might be more ambiguous. Or I might meet criteria for a lot of these different disorders. Moral injuries are a related construct, but instead of focusing on potentially psychologically traumatic events, things like car accidents or risk of harm to oneself or others or sexual violence, moral injuries involve the elements that can impact our psychological, our emotional, or our spiritual experiences. When we see or are forced to participate in something that violates deeply held morals, deeply held values of ourselves. So it doesn't necessarily require that there's a potentially psychologically traumatic event involved, but it might. The two of them together, we are seeing increasing evidence, can substantially increase challenges with respect to mental health for all of our public safety personnel. Because quite often we are deploying our public safety personnel to deal with an event, and that event might also have a injurious component to it where someone is badly harmed, and it might also, though, be associated with moral elements, like someone should have prevented this, or someone did this maleficently, someone did this with willful bad intent. Could also be associated with a variety of organizational betrayals or perceptions of community betrayals. So together, these all increase risk for a variety of different mental health injuries. Let's click on to the next slide. Since around 2018, we were able to publish evidence indicating that our public safety personnel across the different sectors are screening positive for a variety of mental health disorders much more frequently than the general population. And some of these data points are in the process of being updated right now, but the National Police Federation did one of the most recent updates where they were able to demonstrate that relative to when we did the data collection in 2017, when we did another data collection with the RCMP members in 2023, we've seen actually a substantial increase in their mental health injuries and the positive screens for disorders, going from 1 in 2 to 2 in 3. Part of this is the incredible stress that all of us have been under over the last 5 years, with compounding challenges associated with things like COVID-19 and other stressors. But I highlight this because I think it's easy for us to forget just how large this challenge is for our public safety personnel, and that while we are all trying to navigate various stressors, they're the backbone that is providing us with support for some of those most extreme stressors. And we're seeing evidence that their mental health is taking some pretty significant hits as a result of that. Let's click on to the next slide. In addition to those positive screens for mental health disorders, we also know that there are challenges associated with suicide, and suicidal ideation, planning, and attempts are some of the best predictors that someone might die by suicide. But you could have all three of those things and never die by suicide, or you could have all of those things just once and die by suicide. And for our public safety personnel, we are again seeing higher prevalence, higher proportions of them reporting difficulties with these things than we would expect in the general population. You see a fair amount of variability in this case across the different sectors. But in all of these cases, part of why we're so concerned is that for most of our public safety personnel, the distance between a suicidal idea and a lethal attempt is actually much shorter for a lot of them than it is for the rest of us. In some cases, it can be the distance from their hand to their hip. We're also seeing, as a result of rechecking the data from the RCMP, that in fact, those numbers have also increased during the last 5 years, likely as a result of difficulties that we're all experiencing because of the recent stressors. Let's click on to the next slide. All of these mental health challenges and these psychological challenges are being compounded by a variety of organizational and environmental challenges. They have difficulties with stigma that preclude them from accessing care. And in fact, because they're the ones we call for help as those help givers, as the people who are there to protect and serve the rest of us, quite often they experience multiple levels of self-stigma and other stigma and organizational compounding stigma. We're hearing that's still true today, although we are seeing really substantial improvements in that. We've also seen compounding problems from COVID-19 and increased levels of burnout. We're also seeing evidence of difficulties across the sectors with recruitment of new people and retention of their existing team members. Part of this is related to the stressors, and part of this is related to the increased communications that are really showcasing that these are critically important members of all of our communities, and that we are straining them beyond what they are reporting as a sustainable capacity. That is also all rubbing up against stoicism and the fact that these community members experience and are sort of bred into, or brought up, into a very stoic culture. So when, for example, I've got a public safety person coming to save me because of my car accident, they do present themselves as being quite stoic, and we need them to in that moment, right? The firefighter who's using the jaws of life to remove me from the car, it's really not great if they're crying in the middle of that process, right? We need them to have that capacity, but we also need to recognize that that capacity is there for our benefit and does come at a cost to them. And that cost is creating more problems with stigma and making it more difficult in many cases for them to reach out and get help. And when they do reach out and get help, we are also running into challenges because we need to make sure that there is available, culturally competent, experienced, evidence-based care provision available to them as soon as they do reach out. And making sure that that is available is a huge challenge at a high systems level that we're all working on together. Next slide, please. We do know that peer support can be an incredibly powerful set of tools that can help to offset some of these challenges, and can help us also offset the challenges with needing more access to evidence-based mental health care than we necessarily have. Now, there's a lot of debate around the kinds and levels and different forms of training and different peer support models and different peer support programming that's available. And we're trying as a research community across the country, and in fact around the world, to narrow that, to get more research data so that we can give our peer support providers and our public safety personnel better evidence-informed and evidence-based practices. That's going to take some time. But what we do know already is that the provision of peer support can be a very meaningful and beneficial thing that can increase connectedness, that can break down and reduce stigma, that can facilitate evidence-based help seeking, and it may in fact be more acceptable for PSP to seek help from their peers than it is to outside mental health professionals. We've got some early research evidence that shows that that's in fact quite true. While they might be more reticent to reach out and talk to a mental health professional, they are more likely to reach out and talk to, first and foremost, their family members and their close friends, and then their community peer systems. So if we're providing support to those peer systems and making sure that we're working and collaborating with them, that provides us with another opportunity to try and better support all of our public safety personnel. Next slide, please. We also know that there is no currently singular model for what constitutes when a member of our PSP community is actually personally in crisis. I mean, we've got some general models that we can use. So someone who's actively or acutely suicidal, that's a human being who's in crisis. But being able to differentiate when, for example, a member of our PSP community is just on the verge of crisis or in crisis, but not quite yet at that more catastrophic level, this is something we need more time and more research and more support to really suss out so that we can provide you with evidence-informed solutions. But what we do know is at this point, a significant mental health distress or an experience of significant mental health distress can be considered, at least right now, to be a crisis that might manifest in a variety of ways and would benefit from someone reaching out for additional support, perhaps initially with peer support and then as needed with that evidence-based support from a mental health care practitioner. All of our PSP are probably at higher risk for just about everything because of what we're asking them to do. But they are at higher risk for suicidal ideation, planning, and attempts, and they're more likely to engage in that impulsive decision-making as a result of that ongoing stress. Anytime we put a human being under ongoing and continuous stress, protracted stressors, if you will, we are reducing their capacity to be making the best possible choices that they can, and that over time can reflect an increased risk. We also note that the lack of literature done specifically on crisis interventions, specifically for PSP, really underscores the need for more research and programs. There's some systematic reviews that have been published recently that are available on the CIPSRT website, and they will all underscore the same thing. We're getting a handle on some of these pieces of the puzzle, that we need early access to evidence-based care, we need regular things like check-in and ongoing perceptions of support, but we also need more research to make sure that we're building the most effective solutions possible to support all of them. Next slide, please. So overall, for where we're at in the literature right now, we believe that there are a variety of well-being programs that have increasing amounts of evidence behind them, either being evidence-informed or evidence-based. They can help support and inform crisis interventions, that they themselves can be evidence-informed and ultimately evidence-based. And we have a host of mental health services that are available that include a wide variety of evidence-based solutions that, as long as we can make sure our PSP access them, can be a huge benefit as well. That said, in my opinion, it's going to be a constellation of these solutions, a confluence, if you will, the coming together of a variety of levels of intervention and a variety of levels of supports that are going to really help us to bend those numbers so that our public safety personnel have a better chance of not experiencing ongoing mental health challenges, and maybe we can bend that curve so that we can provide much more protection and service to those who provide so much protection and service to all of the rest of us. With that, I'm going to turn it over.
And that's to me. Thank you so much. That was a very rich presentation, and I think really sets the stage for thinking about what are some of the services that are available. I'm Alison Crawford. I'm a psychiatrist at CAMH in Toronto and professor at the University of Toronto. And I'm the Chief Medical Officer for this new service, 988, Suicide Crisis Helpline, which, as the name suggests, is a 3-digit number that people can call or text to access crisis support, particularly if they're experiencing a suicide-related crisis. And my team is also funded through CIHR to, we've created this thing called the Respond Hub. So to figure out how to make crisis services, including, but beyond that, including 988 and beyond that, accessible, meaningful to public safety personnel. So through that, we do some of our own research, and we also support other teams and collaborate with other teams. And Dr. Ellis and Dave McLennan, this is part of that collaboration. So I'm going to cover a few slides, just letting people know about the 988 service and what it involves, and some of our PSP research. And then I'll hand it over to Dave. Okay, next slide. And then next slide. Great. So the 988 service can be reached by calling or texting. It's available to anyone in Canada from any province or territory. Again, it's really being targeted to those who are struggling with suicidal thoughts or behaviors, but no one who reaches out to 988 will be turned away. So it is a crisis service for really anyone, and also for caregivers or family members. Anyone who's concerned about someone, you can also use 988 to reach out. And if we go to the next slide, and the next slide. And one of the primary concepts with 988 is support close to home. The idea is that we didn't want to create just a single call center model. We really think that there's a lot of value in community-based involvement in suicide prevention. So the 988 service is a network of providers, and you can see by the circles on this map there, we have providers in every province and territory. And they are the ones, so we provide the technology, so anyone who calls 988 will be routed as close to home as possible. And they, I think, actually the next slide has a few more details before I launch. Okay, no, already at the numbers. So essentially, when you call 988, you can receive service or text in English or French, and we have some specific options right now. Those are 2 additional options. One is if you're 18 years of age or younger, so probably not a public safety personnel, or if you're First Nations, Inuit, or Métis and want to receive service from Hope for Wellness. But we are trying to figure out within this service, what is the best way to provide support to public safety personnel who call. So I'm going to give you an overview. Actually, if you just go back, sorry, to the previous slide, I just want to give people a sense of the numbers. So this is the first 5 months of our service. These are the total numbers, but I should also note they're increasing. And what the prediction is that we will receive over 1 million contacts by phone and text per year. So it's a heavily used service, and it does tend to be people who are really in need in that moment. So far, we've been able to, answer the phone, answer the texts very speedily, and there are about 1,000 responders working across the country to achieve that. And next, you can skip to 2 slides ahead. Okay, so what are the crisis needs of public safety personnel? You've heard the punchline, which is there's almost no literature on this. There's a lot of need, a lot of interest in it, but there's almost no literature. So our response study is, first of all, concerned with, do public safety personnel even call a service like or text a service like 988? Because initially people were thinking, no, they probably don't. And there are lots of barriers, which is another thing that we're trying to understand. What makes it a trustworthy service? Why would a public safety personnel feel comfortable or find it meaningful to call this kind of a service? So we're answering that question in a few ways. If you go to the next slide. Okay. So at the center of our project is a really strong involvement of public safety personnel co-researchers. So we have co-researchers from pretty much every major public safety profession, and we're doing a number of things, including analyzing calls and texts that have already been made over the last year to 988, and also a survey that I'll tell you about in a moment of public safety personnel across the country. Everyone hates surveys, so that's a challenge, but really understanding people's crisis needs and what is meaningful to them. And then we're going to take all of that information and work with our co-researcher group to create resources to try to make 988 a more meaningful service to this pretty heterogeneous group of people. Next slide. What have we found so far? So over the course of a year, you could go to the next slide, we have found 119 phone interactions by public safety personnel. It's challenging to identify them because that's the first barrier. Not everyone who calls or texts identifies themselves as being from a public safety background. And so we've already changed practice by asking now. Our responders ask callers if they're from one of these groups. But these first 119 call transcripts are really, and you can see the breakdown of who is calling, primarily firefighters, paramedics, and law enforcement personnel, at least who are being identified. And what we're going to do is an analysis of why people call, the kinds of things they find helpful, what their needs are, what the resources they're looking for, and whether the service is effective. And next slide. And this will give you a sense of, female public safety personnel tend to text, males tend to phone, but overall, it's a fairly young group that is utilizing this service. So that's already another point of potential intervention. It's obviously there's less stigma, or we need to understand why it's younger folks who tend to use the service. And next slide. The other thing that really comes across, even from those 119 transcripts, so you saw the information that Dr. Carlton presented about different suicidal thinking and behavior. In this group that actually uses the 988 service, it's even higher. So this is a very at-risk group that is using the service. And that already has been a meaningful finding because it really shows that people who are very at risk are the ones that do tend to use the service. And I think I have one or two more slides. Next one. I've covered most of these things. We're really at the beginning of our data analysis. So we're really looking forward to understanding more, not only understanding what the barriers are, but what people find helpful so that we can then use that information to improve the service. And I think I have one last slide. Oh, yeah, next one. So we also have a survey because we also want to understand people who haven't necessarily used the service, whether they would use the service, how they perceive the service, 988 service and other crisis-related services. And you'll see we've had about 600 people answer this survey so far, primarily from Ontario, primarily EMS folks, because that one of our co-researchers, she's super active and she's getting those EMS people to fill out this survey. So I have one last ask before I hand over to Dave. If you go to the last slide, if you do want to fill out the survey, please do. If there is anyone you can distribute this survey to, please do. So there's the QR code. I'm going to really draw out this slide so that you can all get that QR code. You can also just go right to our website, which is respondhub.ca. And it's just super important. In order for our results to be meaningful, we really need people to fill out the survey. Other thing we're super excited about is working with Dave, with Janet, with this whole amazing team to really think about what a service might look like where we can at least allow public safety personnel that call or suggest that they connect with a peer support, because we know that works. And I'm going to pass it over to Dave because that's the program we've developed with Boots on the Ground, and that is being researched. Thanks. Oh, sorry, I can't hear you yet, Dave.
We're just muted there.
Sorry, my bad. I do that all the time. Thanks very much. It's an honor to be here, and a real honor to be working on this project with Janet and Nick and Allison and everybody. Boots on the Ground is really honored to be involved. I'm a retired police officer. I served 30 years with a municipal police force in Ontario. And then at my retirement, I founded Boots on the Ground. And Boots on the Ground is a peer support organization that's 24/7 anonymous peer support for all first responders across the province of Ontario and Alberta. And we provide services to police, fire, EMS, corrections, nurses, the military, and we don't turn anybody away. So anybody from any public service organization can contact us for assistance 24 hours a day. And we offer our services anonymously, which is really important, and it helps get around that challenge of stigma. So what we do is when people call into our phone line, your phone number is blocked, so it shows up as no caller ID. And we don't ask your name, we don't ask what service you work with, we don't ask where you live. All we ask is, are you police, fire, EMS, corrections? Tell us what you do for a living, and that's it. And we're finding that's huge, and it's helping get around the stigma and letting people open up and talk about what's bothering them. So we are a charitable organization, and we're completely run and staffed by volunteer first responders. And on my retirement, I felt passionate about the impact that the exposure of trauma was having on public safety personnel. And I thought I could bring together a group of people with passion for this. And I was amazed. I put out an email to 25 of my colleagues, and 24 said right away, I'm on board, let's get this going. So we saw a need for external resources separate from the employer. And it's really important to say that organizations are doing a great job with their peer support teams and their org wellness teams, but there's just that certain percentage of the population that won't go to work for help. Fears related to stigma, confidentiality. Is this going to have an effect on my career? As a police officer, are they going to take my gun away if I ask for help with mental health? Firefighters, are they going to take me off the truck? So that's why it's so important to have anonymous external resources for people to contact. Next slide, please. So all of our people answering our phones are first responders or public safety personnel or retired public safety personnel. And they receive up to 12 days of training before and during the times that they're on the phone line. So they get peer support training, assist suicide prevention training, officer resiliency, before operational stress, Indigenous awareness, bereavement, mental health first aid, military veterans and wellness. So we do 12 days of training for our volunteers. So they are trained along with being peers and being able to listen and empathize. They have some good training to help the callers out. And on top of that, we're grateful enough to receive some training for our peer volunteers for the Caring Contacts program itself. Next slide, please. So we found it to be incredibly rewarding to be able to help our fellow first responders in this way with peer support. And we've answered over 3,300 calls in 5.5 years. And we know it works, we know it helps, and we're getting positive feedback about it. And first responders just want to talk to someone who's been in their shoes, who's been there, who gets it. And one of the most important things is first responders, we don't want to go home and bother our families about it. We don't want to go home and talk about bad calls to our wife, our spouse, our partner, our children. So being able to talk to someone who gets it, and you don't have to worry about upsetting us on the other end of the line, that's huge. Next slide, please. So as I mentioned before, we've answered over 3,300 calls over the phone. We also do in-person peer support. And of our 3,300 plus calls, we've only had 15 requests to meet in person. So I think that highlights the importance of the anonymity and how the anonymity is helping get around the huge issue of stigma. And we're still finding that stigma is the biggest issue preventing first responders from calling in. I still answer the phones on a weekly basis, and I can tell you the first couple of questions I get all the time are, can you see my phone number? And is work going to find out that I've called? So it's still a huge factor. And we're, like Nick mentioned, there's great programs around there to help get around these things. So our call volume and demand for our programming has increased steadily over the last 5.5 years. And I also believe that COVID had an impact on that. First responders not knowing whether they could even go home during COVID, where they're going to infect their families. There were huge stressors, and I think that increased our call volume as well. So we started with 50 volunteers in 2018. We have 180 plus volunteers now in Ontario. And last September, we opened an office in Alberta. So we are operational in Alberta as well. And we're looking at expanding next to BC and across the country. We have interest across the country to build out boots on the ground. And at launch, we provided our service just to police, fire, EMS, and corrections, but we started getting a lot of calls from nurses, a lot of calls from military personnel. So we've expanded our volunteer team to include those people, and we offer our services to all of those organizations. Next slide, please. So at Boots on the Ground, we found it incredibly rewarding to be working with the team at the Caring Contacts and to be able to help first responders in another different way. And we found that there's really no difference in answering or doing these calls. We're used to receiving calls at Boots on the Ground, but we're finding that there's really no difference. The people who are willing to take the calls from us are expecting the call and they're accepting of the call. And we're finding our volunteers who have done those calls have found it to be very positive experiences. It's just another way to help our fellow first responders in their time of need. And it's so beneficial to be able to offer hope and resources. Sorry, the next slide, last slide. It's so beneficial to be able to offer this hope, and the hope comes in so many forms. It comes in just having someone who understands and empathizes. And the biggest one is it comes in the form of offering resources for ongoing support. So peer supporters, we're not clinicians. We can't offer that kind of help, but we can offer clinicians who can offer that kind of help. And it's amazing the number of first responders that I speak to, and I say, hey, how about talking to a clinician? You might benefit from that. And because they're under so much stress, they're under whatever's going on, they say, oh, I never thought of doing that, or can I do that? And absolutely. So that's part of offering hope, is offering the long-term solutions and help that can help them through the toughest of times. So as Dr. Carlton mentioned earlier, isolation is huge. First responders who are off with mental health injuries often feel isolated. As coworkers, we don't know what to do. We don't want to call and make things worse. Nobody knows what to do. So as a result, a lot of people are isolated, and that's a huge thing. So having these Caring Contacts calls and having peer support to offer helps with that isolation, and it helps that things don't end in tragedy. And giving people validation for the way they're feeling and empathizing and listening is huge. So we've experienced great positive results from doing these calls, and we're just honored to be involved in this program. So thank you very much.
Thank you. I realized I was so keen to introduce the study. I did not introduce myself, but I am a medical psychiatrist. I specialize in PTSD. I work at Sunnybrook Health Sciences Center. I see police officers, and I also have a professorship in veteran mental health through the Temeti Faculty of Medicine at University of Toronto. And so I see military personnel and veterans. So back to the study. So we created a working group, and we're very grateful to have assiduous attendance from Boots on the Ground and 988 and Sunnybrook psychiatrists specializing respectively in suicide prevention and in Caring Contacts research, as well as psychosocial supporters with expertise from Toronto Police and Orange, and the Chief of Psychiatry for Canadian Armed Forces. So we met, the main aim was to make sure that we got full feedback from this array of expertise whilst we developed our study materials, the way that these concepts would be communicated, what types of input could be given in terms of how the research could be ethically conducted, because we're fully aware that the concept of caring contacts, for example, is that it should be non-demanding, and fully aware of the inherent difficulty of asking somebody who's been in crisis whether or not they'll participate in a study. At the same time, we are aware of how important it is and how needed it is to have research in this area, and that the rate of suicide continues to be high, in fact increase, and yet we don't know about this critical time of being in crisis and what type of interventions work and don't. So next slide. So the theoretical model for the CCPI, on the one hand, on the left, you can see that it's employing these two evidence-informed interventions, caring contacts, which is the early follow-up for high-risk individuals at high-risk times, and peer support with honest, validating conversation from peers who understand and appreciate the challenges in the work environment, having been there themselves or still being there themselves, and that this combined intervention should then target the mediators to reduce occupational stress injury and help prevent suicide. So to increase social support, a sense of belonging, not being isolated, a sense of belonging to this community, that it should decrease stigma of help seeking, because after all, if you're speaking to somebody who's already trained in peer support and is a PSP, that automatically will decrease the stigma of speaking about sharing distress. And as everybody has so far eloquently talked about, the importance of increasing a sense of hope, and capitalizing on knowing that caring contacts has been shown to, in some way that probably we don't still fully understand, increase a sense of connectedness we can understand, but purpose may be a little harder, and meaning in work. But that's the research finding, and we'd like to understand more about it. So next slide. So again, if you prefer it pictorially recommended, identified, but social support, community, a sense of belonging, hope, a sense of purpose and feeling connected, and overall decreasing stigma, and obviously mitigating occupational stress injury and improving suicide prevention. Next slide. So how does it work in this study? So the PSP callers in crisis are identified by 988 hub responders, and they're asked, once they're identified, assuming that it's appropriate. Clearly, if somebody's in very high distress and there needs to be a particular type of support given, then it may be that it's not appropriate at that very moment to offer this follow-up call. But if it's appropriate, they're offered this support, and the confidentiality of boots on the ground peer supporters is emphasized. Of course, in a way, we're breaking with protocol, because people do have to share their name and number to then be shared with boots on the ground. And so we're very aware that boots on the ground has been willing to participate in this, and we've gone to great lengths in our ethics application and in the design to make sure that confidentiality is maximally kept. And then boots on the ground then make the call within 48 hours and 7 days to the PSP callers in crisis to provide the CCPI intervention, which is the 2 follow-up peer support calls. Next line. Next slide. So again, pictorially, the 988 offers the identified PSP callers the peer support boots on the ground delivers the intervention, and if appropriate, again, at the end of call 1 or call 2, offer the opportunity to participate in this study, emphasizing why the study is being done and emphasizing confidentiality. And then finally, independent of whether or not we manage to recruit the callers in crisis, we will be able to look at the feasibility of the implementing the CCPI, as well as the acceptability to the peer supporters. But we very much hope that we'll be able to also understand more about the experience of the callers, and whether or not what their needs were, whether their needs were met or not met in this call, and whether or not it was acceptable. Next slide. So it is only a pilot project. It will be using both qualitative interview data with PSP callers as well as the peer support facilitators, with some quantitative survey data. We hope that we will be able to reach 20 to 30 PSP callers to participate in the study, and estimated that we'd be able to offer 45 the intervention within a 6-month period. We will be looking at reach, like which populations, which PSP populations accept this support, what type of uptake is there of the actual calls, what number want 1 call or 2 calls, hence looking at the feasibility and acceptability. And the data, the feasibility data is being tracked by the 988 hub responders. It's completely anonymous and confidential. All we know is how many PSP have been identified, how many said yes to the to the peer support intervention. And then we know from boots on the ground peer facilitators, again, completely confidentially, we know whether or not 1 call or 2 calls were received. And then in people who agree to participate in research, we'll be finding out more about the experience of the intervention, met and unmet needs, and some understanding of what the peer supporters felt providing the intervention. Again, not only have we asked boots on the ground to actually deal with contact information, but we've also asked boots on the ground to actually make a phone call, as opposed to simply being there ready to receive a phone call. So we wondered whether there would be a difference in calling somebody, choosing to call somebody who we know is in crisis, versus them calling. So there were all sorts of questions that were raised in this study. Next slide. So we did foresee some challenges, and we had some possible mitigation strategies. We certainly have not had any problem in having PSP volunteers, peer supporters from boots on the ground. They have been absolutely amazing and available, so that has not needed any mitigation. We also worried about PSP callers in crisis being distressed during these follow-up calls, considering it's a new intervention, but thus far, as you've heard, it doesn't sound as though that's been an issue. Nevertheless, it's something we're acutely aware of, and we have the ability to respond appropriately. And boots on the ground and 988 already have their own protocols, and will follow them absolutely accordingly. We worried that volunteers might experience a stress or burnout. We know that Boots on the Ground has a good, strong community of practice, and we are willing to offer further support if needed. I say it like that because we've only just started, but those are some of the things we were concerned about. Next slide. So we co-developed these materials for training with our working group, and 988 kindly participated in training their hub responders, and 109 hub responders have been trained in the idea of CCPI and what is required for this study, and 12 boots on the ground peer facilitators, call responders went through orientation, and so far in the first 2 months we've had 24 PSP callers identified by 988, half of which were offered the CCPI peer support intervention. And then of these, of the 9, 2 have agreed to participate in research. Next slide. That just shows how the data is collected. Next. So clearly, the challenge and the mitigation strategy that's required here is we need to be able to recruit the PSP callers to give us more information about their experience, if at all possible. So we're trying to make sure that the reason that we are doing this study is really emphasized, that we really want to understand the experience and improve interventions for PSP in crisis, that there's a need for that. There will be even more emphasis on the fact that it's 100% confidential, despite the fact that it's a research study. There's no way that information would ever be personalized or recognized, and that furthermore, that participation in the study doesn't impact whether or not they're invited for the second peer support follow-up call, and hopefully being able to mention the study in a way that is approachable and natural and doesn't impact the established rapport between the peer supporter and the caller, or the overall experience of the CCPI. So you can imagine that's a difficult balancing act, and those are some of the areas that we continue to think about how to solve them. And if anyone has any ideas, let us know. Next slide. So, of course, knowledge translation is always very important, and our goals are to address the stigma of accessing mental health support for PSP, and to normalize interventions for PSP in distress, and to share the insight that we develop on crisis line follow-up interventions for PSP. And for that, we're extremely grateful to CIPSRT for this opportunity, clearly, and to 988 for allowing all their responders to be trained, and for the boots on the ground peer facilitators to have gone through the training. And we've co-developed the tip sheets with our working group on the CCPI intervention. We're busy preparing a scoping review on interventions in PSP in crisis. As the one slide that was spoken to about the difference between wellness programming on the one hand, and on the last hand, the mental health support in the middle, is what we don't know about. We don't know about intervening in crisis. How do we identify people in crisis, and how can we meaningfully intervene in a way that is helpful? And on that note, I'd say thank you so much.
Great, thank you all. That was wonderful. We'll take any questions now. So anyone in the audience, if you want to write a question in the chat, questions box, we'll read them through. So the first question that's come through, have any of the panel been to or observed a treatment or retreat program for first responders?
I haven't been to one, but I've observed some equine therapy for first responders, and it's incredible. And the results they're getting from it are incredible, and the feedback from all the participants have been amazing. That's the only one that I've been to. I'm aware of a lot of treatment programs for first responders, but have only observed equine therapy.
I'm in the process of joining an occupational stress injury clinic to be part of a team intervening, And I've certainly been in retreats for similar retreats, but not specifically for first responders. I don't know, Nick, if you have.
I've seen a few. I've seen a few. I'm having technical difficulties. I've seen a few different ones. There's a lot of variability in length and in the kinds of programming that they're offering in the retreats and in the kinds of interventions that are being offered, as well as the kinds of targets with respect to the specific symptoms that they're targeting. So I think we're in very early days with respect to assessing the short and long-term impact of any of those kinds of interventions. And hopefully the variability will mean that we'll get a lot of different research results, and then we can give some really good feedback on what works best and what could use some tweaking going forward.
Great, thank you. We don't have any questions at the moment. If anyone has any maybe closing comments or anything you'd like to say, please take the floor.
I'm going to leave this to the others who've been in this field for longer than I.
That would be Nick and Dave.
There you go. Would you like?
I'll just say thank you. Like the work that everybody's doing, certainly Dave, but Janet and Allison as well. These are huge differences. And when we start looking at trying to improve peer support programs and look after suicidal ideation planning and attempts to better protect our public safety personnel, this is really critical. And I think we're seeing them at the absolute leading edge of the investments in time, effort, research, and evidence to try and protect all those who serve. So I'm extremely grateful for their expertise and their commitment to the area, and extremely grateful to all of our public safety personnel for protecting all of us. I'm looking forward to being able to do a much better job of helping all of you collectively as we go forward together.
I'm going to sneak a peek to the second question, if you don't mind, because I don't know if Alison and Nick have thought about this, but the question is that AI has been used as a tool for companionship, as a personal choice. What do you think about the idea of future AI tools as an intervention in this population?
Well, it's interesting. I've used some of them, and they are scarily good. And it can be very misleading. I have a lot of ethical concerns. I think it's inevitable that we ultimately will incorporate AI into pretty much everything we do, but I think we have to exert extra care when it comes to supporting people in crisis. I know there was, I believe it's the Eating Disorders Association, either Ontario or Canada, and they replaced their live crisis response with essentially an AI mediated response. We're actually very careful at 988. We let people know it's a live responder that you will get, because I think that has meaning. And until we know more and until we understand the ethical issues better, it's definitely not a road I would go down.
Can I very quickly, Carolyn, respond to the next question, because I've got a strong interest in it. So the question is there a program or studies on healthcare workers in hospital settings for moral distress, PTSD, etc.? And I can certainly speak to that. There are many programs that have been developed. We're way behind populations like police and fire in terms of rolling out wellness programming in healthcare. But I certainly was involved in rolling out a particular wellness program called Steady in COVID across our hospital in 10 units and teams. And yes, there certainly are established well-being programs, but they haven't yet been adopted across. There's also lots of good idea of peer support apps that are being researched nationally.
I'll just add one thing to that, Janet, which is that on 988, when we were looking for the number of public safety personnel who were calling or texting, what we discovered is the very high prevalence of nurses that reach out. And so that's led us to kind of set up a parallel study looking at the needs of nurses. And I think it's there's a way to understand healthcare providers as being public safety personnel as well. I think that's a bit controversial, but certainly there are people who serve us and endure high rates of distress.
Great. Thank you all for your responses. We are at 1 o'clock and we have no more questions, but I really want to thank you all for being here today. This was wonderful. So thank you very much.
Thank you.
Thank you.
Thanks, everyone.
Thank you again to all three of you for your support and investments. I appreciate it. I'm looking forward to going forward together. Take care, everyone.
Thank you.
Thanks.
Likewise.
Bye.
Thank you.
Thanks so much, and thanks, Carolyn. Very